Okay, I think we're all in here. Welcome to Frontiers of Medicine. My name is Steve Tanney. I'm with the George Washington School of Medicine and Health Sciences. Thank you all for coming out on this warm, balmy evening tonight. I know you had a nice leisurely stroll over here. This is a season of giving thanks, so I did want to take the opportunity to thank our donors who are here tonight for their support of George Washington Medicine. Frontiers in Medicine is a lecture series that we've been bringing to the community for the last 3 years. Tonight's session is the first of an occasional series about healthy aging, which we will continue in the new year. It's a topic of universal interest, because after all, we are all aging, if we're lucky. Before we start, just a little reminder about process. When you came in, you should have received one of these pads. Those are for your questions. So if you do have questions, please write them down on the pad. There will be people who will come and collect them and bring them to our moderator. So without any further delay, let me introduce our moderator, Dr. Alan Wasserman, who is Eugene Meyer Professor of Medicine and Chair of the Department of Medicine. Dr. Wasserman.
Thanks, Steve. The reason you have the pads is so that this way I don't have to do any work at all. You can write down the questions and pass them up, and I can just ask your questions for you. I'll try to get to as many as I can. When we put together this series, we decided, we tried to figure out what should we start with. And I thought about all the times my son claims I don't hear him, and how my wife complains that I can't see at night when I drive anymore. And most of us are from the generation where we laid out in the sun with our reflectors and made sure we burned to a crisp, and now we're paying the price by visiting the dermatologist as often as possible to get our basal and squamous and other things removed from our bodies. So it seemed to me that if I'm starting to see these problems, that probably other people are too. And these seem to be three topics that I thought would be of interest to get started, and I hope they are, because we got three terrific people here today to speak, and we're going to give each one a chance to do a short presentation, and then we'll take questions at the end after everybody is done. So we're going to start with the ear. Can everybody hear me? Dr. Ashkan Monfred is board certified in otolaryngology, ear, nose, throat, and serves as director of otology and neurotology here at GW. He completed his medical training, residency, and fellowship at Stanford University Medical Center, and as a researcher in the areas of acoustic neuroma and inner ear imaging, he has authored several peer-reviewed scientific papers and book chapters. At GW, he's gone a long way to create the Comprehensive Hearing Center, which is one of the only adult cochlear implant programs in the metropolitan area. We were absolutely thrilled when we were able to recruit him to GW. It took a lot of work and a lot of people to do this here, but we're extremely proud that we offer this comprehensive center for hearing. And we're pleased to have him here, and I'm really pleased for him to be our first speaker today. Ashkan?
Good evening, everybody. I will be glad to answer any hearing problems that you may have at the end of the talk, any listening issues, such as what Dr. Wasserman pointed out you need to see a family therapist or psychologist for. So, also, if you're wondering about interesting lesions and rashes growing on different parts of the body, Dr. Ehrlich would be able to handle those for you at the end of the talk for you. So I'm delighted to be here. Thank you all for attending. Dr. Wasserman and Ms. Tanney, thank you so much for having me. As Dr. Wasserman mentioned, we started a comprehensive hearing program here at George Washington University to be able to help people from slight amount of hearing loss and tinnitus to people who are profoundly deaf with cochlear implantation. It is an exciting time for hearing sciences because of all the advances that have been done, and we still obviously have a long way to go. Let me see, I advanced the slides with, I should have done this before I came up here, but I didn't. Is this the? There's a laser beam on this. I don't want to evaporate anybody, so let me just make sure this is the right.
Yeah, I believe it's,
Just a green button.
yeah, I think it's the green button. There we go.
All right. Okay. So we'll have a quick overview of human hearing, and then I will talk about what is an optimal device for hearing. We'll talk about some of the new interesting implantable hearing devices that have come to the market, and end with cochlear implantation. So in a normal hearing, this is where I press the laser. Let's see if it works. There we go. You have the sound enter the external ear through the ear canal. It hits the eardrum, goes through these little bones of hearing, and the vibrations get transmitted to the inner ear, or the cochlea and the vestibule, which is responsible for your balance and your hearing. And then the signal gets transmitted through the nerve into the brain, and that's how you hear sound. When there is any problem with the first portion of this apparatus, including the outer and the middle ear, you will have what's called a conductive hearing loss, as in the sound is not being conducted very well. Anything that deals with the cochlea and the nerve of hearing, we call it a sensorineural hearing loss. Examples of which are the most common reason people have conductive hearing loss is wax impaction in their ear canal. The most common example of people having sensorineural hearing loss is aging. As we get older, we all lose hair cells inside the cochlea. There's no exception. We all do. There are sounds teenagers can hear that none of us in this room can hear. There's actually a riot police weapon that they can use to expel teenagers by using these ultra-frequency sounds, because the police and other people won't hear them, but teenagers would. So you can use that at home if you have an obnoxious teenager. So just a few words about the demographics of hearing loss in the United States. Guess what percentage of the people in the United States over 55 actually have clinical hearing loss? Again, not a listening problem, but clinical hearing loss. It's about a fourth of people over 25 have clinical hearing loss. And I bet you with all the iPod and iPad and this and that, these numbers are dramatically increasing in future. Once you go over 65, it's about a third of the population in the United States have clinical hearing loss. So you have issues with not hearing your spouse. These are most likely an issue of hearing, not listening. And I guarantee you most of the patients I see in the office for hearing loss are brought in by an angry spouse saying, make him listen to me. So what percentage of these people do you think actually use hearing aid? About 1 in 5. And out of those, 15% just get frustrated and eventually just give up. And what is the most common cause of hearing loss in the United States? It's a trick question. It's just wax impaction. That's the most common reason people feel they can't hear. And that's why, unfortunately, so many of the more challenging and more dangerous types of hearing loss go unnoticed, because people think it's just wax, it'll go away by itself, or I'll just wash it out and it'll be fine. So when you visit an audiologist, they do what's called a hearing test, an audiogram, and they will present different tones to you, from low frequency, like a very white kind of voice, to a child screaming at a very high frequency, and they present it at different loudness, and they give you scores of how well you can hear, and based on that, they can distinguish whether you have any type of hearing loss, whether it's conductive or sensorineural, or rarely both. What is an optimal device for hearing? If you think about it, unfortunately, hearing aids have a huge stigma associated with them. Most patients don't use hearing aids not because they are, they're not accessible, they don't work well, is that they feel they lose intelligence points as soon as they put a hearing aid on. Reality, the research has shown, is the exact opposite. There are relationships demonstrated between dementia and hearing loss in the population now. So if you think about it, if you don't stimulate these neurons with hearing sound and speech and thoughts, conversations with other people, they'll eventually stop working. It's interesting because they really don't change your figure, a hearing aid. It hides behind your ear. If you think about glasses, they are a lot more sort of obstructive and cosmetically interfering with your view. But what does a pair of glasses tell other people about you? Smart, intelligence, must be reading. It's like having a fake British accent in movies. You automatically are an incredibly intelligent scientist, which get away with everything. So, an optimal device, for most patients, they say they don't like it to be visible. They want it to be hidden from the view. They don't want it to interfere with lifestyle. They want to be able to go swimming with it. Now, that's in developed nations. If you happen to be a farmer in Ethiopia, like some of my patients are on medical mission, you want to make sure that device doesn't break from sweat when you're working in the field. You want to make sure they don't break from the heat when you're working in the field. You want them to make sure that they're easy to use. If you are an 85-year-old person who has arthritis, playing with these tiny little buttons on hearing aids are not easy. They're actually quite difficult. You want to make sure they're inexpensive. An average pair of hearing aids would cost around $2,000 to $4,000. If you make $1 a day in Ethiopia, your batteries will cost more than that then you can afford in a day. And you wanted to make sure that the device has some level of intelligence in it, as in it hears what you want to hear. Hearing aids at this time, they amplify the environment. They don't know what it is that you want to listen, whether you're interested in speaking with your spouse or you're eavesdropping about the conversation in the next booth. The hearing aid doesn't know. They just make sounds louder to you. So, hearing aids, unfortunately, a lot of them are visible, but the newer generation of hearing aids that are coming to the market are becoming less and less visible. A lot of them hide behind the ear and have an invisible wire that go into the ear, barely visible to the eye. They do have an occlusion effect, as in when you start chewing, they start making sound in the ear, unfortunately. Some of them would cause feedback. That's that annoying sound you hear every time someone who has a hearing aid that they take it off, it starts whistling. Again, with software technology that's becoming better and better now. They don't know what you want to listen, so sound-to-noise ratio is always an issue, but they are getting more intelligent. They realize most of background noise is low frequency, so they selectively work on bringing high frequency sounds into the forefront of your hearing. They do require constant care, battery change, and all of that. They do impose a lifestyle change. You can't swim with them, for example, or work in a field. They're not cheap, and they don't improve sound clarity. That's one major problem with hearing aids. They only make sounds louder. They don't clarify them. There are two components to hearing. One is loudness of a sound. The other one is the clarity of the sound. There are rare occasions that people have normal or moderate amount of hearing, but they just can't tell what the sound is when it comes in. And hearing aids don't help with that, and that's where we go into the cochlear implant category. A lot of new technologies coming to market. One of the cuter ones that have come this year to the market is called a sound bite. It's a very intelligent marketing name for the device because it uses your teeth to convey the sound into the head. It's designed for people who have single-sided deafness, as in they have one perfect ear and no hearing in the other ear. And patients who have this, they will tell you, if somebody is whispering to the bad ear during a dinner conversation or in a car, they won't hear anything, because the head shadow effect prevents that. In 15th century, musicians realized if you put a musical instrument on your teeth, you can actually hear the sound well, because it gets conducted to the skull very well through your teeth. So the idea has been around for hundreds of years. The technology was not. So what you do is you put a microphone behind the deaf ear, and you put this in-the-mouth device, as they call it, inside around the back two molars, and the sound gets wirelessly transmitted to the sound bite in the mouth and goes through the teeth into the bone, and you can hear it perfectly. Again, you'll hear everything in your good ear, but at least you won't have a head shadow effect anymore. Another device that's come is called a sound bridge, a vibrant sound bridge. This is an implant that you implant these piezoelectric device on the bones of hearing to amplify the sound. Again, it's an amazing technology. The caveat with it is it still has an external piece which holds the sound processor and the battery. So it hasn't advanced to a stage that you don't see anything on the outside. There is a competing device on the market called Steam that is fully implantable. There are two major issues with it. One is battery life. Once the battery runs out, you actually need a minor surgical procedure to change the battery every 2 to 5 years. And you have to disarticulate the bones of hearing from one another. It's a brilliant device. it picks up sound vibrations from your middle ear directly and amplifies them through the middle ear. But you can imagine you don't want to have a closed circuit. You get feedback, so you have to disarticulate the bones from one another. Once the battery problems are gone, these internal devices will probably replace most of the hearing aids, because you just get a surgery done and you're done for the rest of your life. It'd be like a pacemaker. You just interrogate it over the phone and get it working over time. So. The last thing I wanted to talk to you about are cochlear implants. It's a true revolution in medicine, and I'm incredibly surprised that a Nobel Prize has not been awarded for this yet. I'm hoping over the next few years it will. It's one of the only cures for sensory deficits we have in a human being. You can actually get a deaf person hearing again with them. And it's brilliant. I mean, the idea is you implant a coil inside the inner ear or cochlea. By sending electrical stimulation, the human brain can detect it as sound. When the first cochlear implant was being proposed, people are like, this is ridiculous. There's no way it's going to work. You know, human cochlea has trillions of hair cells inside of it. It's not going to work. But it does. The idea came as far as back as Volta, which I'm sure all of you are familiar with, and like every obnoxious child, he decided to put a battery in his mouth and see what happens, but he just went a little bit too high with the electrical stimulation, and he said he started hearing boiling soup in his head by the electricity going through his skull. Then the French surgeon decided to stimulate the cut end of a nerve during an operation and see what happens, and the patient says, I'm hearing sounds, random sounds. So the idea came, maybe we can actually use electricity for people to hear better. And then Bill House and Blair Simmons from California worked on it, and the first cochlear implant was approved by the FDA United States in 1984. It had one electrode in it, that's all. The current ones we use have 24 electrodes in them, and we're limited by the fact that the electrodes leak electricity into one another, so there's not much higher we can go, unfortunately. But with one single electrode, the first person was able to hear sound, who's been deaf for a long time. I will put a few surgical slides here. If you're very squeamish, please close your eyes. I'll let you know when you can open your eyes. This is a child. The surgery is done usually through a very small incision. You know, usually I can incision about this long. It's about 1.5 inches or so. And we create a pocket behind the ear. This is a cadaveric dissection, just so you know where the internal piece hides behind, underneath the skull. And then you drill the bone in front and enter the middle ear and put the implant in there. I put a little video here for you to show you the steps of the operation, if you don't mind, please, starting. It also shows my amazing surgical prowess to you. So, but what I wanted to show you is that there's a little hollow bone behind the ear called the mastoid bone, and you can enter into that hollow bone and enter the middle ear through the back side of it, the posterior aspect of it. There are two nerves here. This diamond burr that I'm using, this drill, is about 2 millimeters in diameter, so you can imagine this is really, really magnified. There are nerves here that control the facial movements. This is the nerve you smile with and you close with your eye. And this little white strand, you're going to see it in a minute, is a nerve that controls the taste buds in your tongue. There's a tiny little window through which, if you drill the bone, it will actually get you inside the middle ear. And you can see now I'm inside the middle ear through the back side. So there's a 2 millimeter gap, which is wide enough because the electrode is 1 millimeter in diameter. And what you do is you open this area, and then you can start seeing the cochlea, or the inner ear behind it. Then you create an opening inside the cochlea and slide the electrode inside. Then you allow the human body to heal, and 2-3 weeks later you can actually activate the device inside the head. And you know, it's one of the most amazing, joyful things you do in your career, because you have a deaf person, you activate it, and all of a sudden they start crying because they hear tones now. Or you have somebody who hasn't heard birds or other things around for a long time, all of a sudden they're hearing high-pitched sounds. One of my favorite patients is this patient. You can see the implant now in place. There's it hiding underneath the skin, and then it's going inside there. I have this patient who is diabetic, all kinds of medical issues, but she's going deaf, and she has schizophrenia. So her doctors are like, please help us out. She's going crazy. We can't communicate with her. And from my end, I'm like, I can do the surgery, but what are we going to do with the training? Because it takes months and weeks of training after that. We finally decided to take a chance, and we implanted her, and we activated her. And we're like, how are you doing? She's like, I'm fine. This is ridiculous. You guys all sound like Mickey Mouse. I don't like this. And she gets up and leaves. I'm like, you're hearing us. She's like, yeah, but you sound like Mickey Mouse. I'm like, we can help with that. It's okay, but you're hearing us. All of a sudden, she starts hearing things around her, and patients say, I haven't heard birds in 20 years, 25 years. I can hear them now. The amazing things are that about cochlear implants, there's a lot of stigma about them and a lot of misinformation about them. They don't give you good hearing. They give you bad hearing. So they're designed for people who are really struggling with their hearing, particularly with their hearing, with hearing aids. It's a major issue with cochlear implants that you can't hear music very well. They can't do frequency and amplitude modulations at the same time. You can go swimming with them. They're actually waterproof. And nobody's ever too old to have them. I've done them all the way in patients who are in their 90s. Every deaf person is not a good candidate for cochlear implantation, because if you have never heard sound and you're in your middle age, your brain doesn't know what sound is. So if you put an implant in there, you will never hear again. You just feel some stimulation, but you don't know what it is. Whereas if you implant a child by the time they're 1 year old, by the time they're 2 even, they make every landmark as every other child does. They do very well. Same with adults who know what sound is. If they go deaf as an adult, they do very well with this. You can use a telephone. About 85% of patients who've never used a telephone, they can use a cell phone after having a cochlear implant. The latest generation of implants, which hopefully will happen by January, are hybrid implants. They have a hearing aid and a cochlear implant in them, meaning they're going to help out with people who have good hearing in low frequencies and a sharp decline in the high frequency. As we get older, this is a population that are really affected by this. And they don't have sound clarity, but they can hear background information, which they don't care, background noise. So these new hybrid implants are amazing, and the data has been exceptionally good for them. Optical implants, hopefully you can imagine you don't have to worry about channels leaking to one another if you have an optical electrode stimulating the nerves on the inside. Genetic engineering and stem cell research, unfortunately, is probably quite a ways away, and more research is needed. Hair cells are the only human cell that do not reproduce. It's the only human cell that has never been reported to cause cancer to this day. So you can imagine how hard it's going to be to do genetic engineering. Interesting fact, though, every animal but mammals can regenerate these hair cells. So it's God's cruel joke to mammals. So anyway, I end here, and I appreciate again your time, and thank you again for having me.
Thank you very much, Ashton. And we'll get to questions later, but don't forget, if you have questions for me, write them down, and we'll have somebody come around and collect them and bring them up to me. Our next speaker is Dr. David Bellier. When I thought about getting an ophthalmologist here, I figured we might as well get the best, so I got mine. So David is board certified in ophthalmology and serves as the vice chair and professor of the Department of Ophthalmology. He's the director of glaucoma services, and received his medical degree from Tufts, completed his internship and residency at the Letterman Army Medical Center, and his fellowship at the California Pacific Medical Center. He's a fellow of the American Academy of Ophthalmology and a fellow of the American College of Surgeons. David's research interests include diagnostic and treatment of glaucoma and cataracts, including the genetic makeup of these diseases. And the wonderful thing about David's research is that most of his funding has come from our former chair and their family of ophthalmology, Dr. Mansour Armley, and we are indebted to his family for providing much of the resources to allow David to do some of his research, and a pleasure to introduce him today. Dr. Bellier.
Thank you, Alan, for those kind words. One thing I found the best way to get rid of teenagers is I just play Lawrence Welk music, and I think that's really the best way of dispersing teenagers, but anyways. And unlike hearing aids, glasses are sexy, right? So the first thing I'd like to talk about in the aging phenomena is cataracts. And something that you might experience is what you see up here on the screen, where you don't lose the vision, but what you see is everything is blurred. And initially that can happen very slowly, and you may not be aware of it, or certain lighting conditions such as dusk and dawn, or driving in the rain, or when headlights strike your cataracts, instead of bending and focusing the light gets diffracted. And then you have symptoms. And you say, well, gee, when I go to the ophthalmologist, I'm in a dark room, there's a black and white screen, it's projected, I see fine, but that's not what I see when I go out in the real world, and that's exactly true. It's a standard way of measuring your vision, but what you're experiencing in real life, different lighting conditions, glare, are what cataracts are causing the problem. And again, there are things that are very similar with ENT that are similar in ophthalmology. In fact, we were at one time one specialty and one board, and we separated out in the 60s. But the lens epithelial cells of your lens, your natural lens, break down, and with aging, they become cloudy or dysfunctional, and they can't transmit the light and essentially not allow you to see. So the cataract, or the word cataract, is Arabic for waterfall. And at that time, when it was discovered, they thought there was a waterfall in front of the pupil, in front of your iris. And in fact, it's not there. It's actually behind the iris, and that is your lens. So when your lens with aging becomes cloudy, right here, instead of bending the light, it diffracts the light, and so you can't see through it. Early on, changing a lens out in front of your eye, wearing polarized lenses or tinted lenses, can help with some of those symptoms, but there's a limit of what can be done. So when your glasses no longer correct your vision to the needs or your needs, then you see your eye doctor, and the ophthalmologist will consider, well, maybe it's time to remove the lens. And when we do that, we do it with phacoemulsification, which is ultrasound. There is some newer technology, and you may hear laser or femtosecond laser, a specific type of laser being done. But that laser predominantly just opens the anterior capsule of the lens. It really doesn't remove the lens, and you still have to have the phacoemulsification. You may hear that noise, and it says, well, it sounds like laser. Well, we give the ultrasound sound because you can't hear it, and that's for the benefit of the surgeon, and because you can't feel anything, giving sound to the ultrasound allows us to do our surgery carefully and successfully. So over here, you can see we're opening the capsule of your natural lens, and then with that ultrasound needle, we stole that from the dentist, not the ENT folks, we use that needle, which is a piezoelectrical crystal device, which generates ultrasound to chew up the lens, because as you get older, your lens gets hard. And so to remove it through a small incision, you have to use ultrasound to go ahead and do that. Now with the cataract surgery, what you do leave behind is your natural capsule of the lens, okay? In that capsule of your natural lens, which is clear at the time of surgery, is what's going to be used to put a foldable implant lens. You can have a foldable implant lens that's a monofocal lens. It can be for near, intermediate, or distance. It could also be a lens that corrects astigmatism, irregular shape of the cornea, so we call those toric lenses. Or you could even have a bifocal lens, which, like a bifocal contact lens, can allow you to see at variable distances if that is put inside your eye. And so again, that lens will go into the capsule, the remaining capsule of your natural lens, and that lens capsule is clear at the time of surgery, but most folks that have cataract surgery, about 10% of the time that will cloud up. And if that should cloud up, that can be repaired, not going back to the operating room, but in the clinic. It can be lasered open, and that's what's called an after cataract. And an after cataract, the symptoms would be very similar to what your initial cataract was, but it can be treated with laser, and that part can be treated with laser, but it doesn't have to require going to the surgery center or to the OR. It can be done right in the clinic. A second thing of where your vision may change as you get older is with glaucoma. And glaucoma is a very sneaky disease. And it doesn't matter how smart you are, because the changes happen very slowly. And they happen so slowly, we are very adaptable creatures, and so we will adapt. Just like your cataract will start very slowly. And you will also adapt with that as well, and not realize that you're not seeing things that you should be seeing. Now, this is only for those with Y chromosomes out there, men, yep, and I include myself. So When you're asking where something is in the house and you can't find it, and somebody says, or spouse says, it's right there, and you says, I still don't see it, and then of course the person comes up and shows you it's right there and you still didn't see it. Well, that's the Y chromosome. So it's not your cataract, it's not glaucoma, but it's probably your Y chromosome. You can discuss that later, but yes, just realize those with 2 X's, we have a disability. Sometimes we see, but we don't see. And as Jerry Garcia and the Grateful Dead said, I have 2 good eyes, but I still don't see. He was talking about his drug addiction. But for the rest of us, it's the Y chromosome, right? So anyways, but glaucoma is very sneaky. And so there's such a drive to see that there will be spots in your vision. You can have various patterns of glaucoma where you may have tunnel vision very late with glaucoma. You may have parts, black spots, where your vision is blurry. You may have blurred vision out in the periphery to start with. Or you may have even missing parts, blurred or black, in your central vision. So traditionally, we think of it as a peripheral vision disease and then happening centrally, but it can do both and simultaneously do both, central vision loss and peripheral vision loss. But usually, in between those black spots, things are clear, whereas a cataract, everything is kind of fuzzy. So that's really the kind of distinction between that. I have a dinosaur theory, is that there's such a drive to see. Patients will come in and function very well, and they aren't really realizing they have a problem until we put you into a visual field machine. Patients say that's a torture machine, but it's not. It's the visual field machine. But what it does is it overrides your brain and forces you to see what you don't see. And I have a dinosaur theory that people who developed glaucoma and couldn't see got eaten by the dinosaurs. Those people that had glaucoma and said they still could see the dinosaur that didn't get eaten, so those people survived, and that's where we are with glaucoma today. But I don't think that's scientific. That's my theory, and don't quote me on that. But seriously, this is a problem. And so because it's hard to detect it's hard for you to detect that you're having a problem. If you do have a family history, if you are having some vision problems, it's always a good idea, particularly as we get older, to get checked out. But particularly if you have a family history, a mother or grandfather that has glaucoma, it would behoove you to get regular yearly eye exams and to make sure glaucoma is not part of your family history or your future, because treated early with medications or surgery or laser, it can, 93% of people won't go blind if it's caught early enough. The problem again is that you have it and you don't realize it. And again, it doesn't matter how smart you are. It's a very sticky disease. So again, 2 basic types of glaucoma. There's open angle glaucoma, where the angle is open and fluid is made behind the iris and the ciliary body, passes between the lens, and it goes out the drain. Well, the problem with open angle glaucoma is you can see the drain. You see the drain looks open, but microscopically it's not open. It's actually plugged. And so when it's plugged, the pressure builds up in the eye. You need that fluid to nourish the lens. You need that fluid to nourish the anterior cornea. There's no blood vessels in your lenses. There's no blood vessels in your cornea. The design was smart, because if those blood vessels were there, they would interfere with light coming into the retina, which is in the back of your eye. But you need the nourishment from the aqueous humor. But if the aqueous humor can't get out, then it builds up, and that pressure pushes on the optic nerve, which is in the back of the eye, and that optic nerve is your fiber optic cable. That actually transmits the vision to the back of your head and the visual cortex. And actually where you see is here. But as we're looking at each other, we see out here, right? We see outside our body, but actually that's actually happening back here. So the signal needs to be transmitted. And so the pressure damages the optic nerve. And once that nerve is damaged, it doesn't regenerate. Another cell that doesn't regenerate in the body. Eyes and ears have very similar tissues like that. And so it can't transmit the signal. You can capture the signal, but you can't transmit it to the processing center in the back of your head, and that's where the blindness comes. Finally, the last thing with the aging eye, we talked briefly about cataracts, we talked about glaucoma, is macular degeneration. And there's lots, and there was just a recent article in the newspaper about it in the Washington Post, and lots of people are concerned about it, because as we are aging, just like the pigmented epithelial cells in the ear, the hair cells in the ear and the middle ear, are very similar to the retinal pigment epithelial cells in the eye, exactly very similar in origin. And in fact, they don't regenerate, and with time they do degenerate. And when those cells degenerate, the retinal pigment epithelial cells, those are the nourishing and supporting cells of the rods and cones. Those are the cells that allow you to see. They capture the light, and then they transmit the light. And without the retinal pigment epithelial cells, you can lose your vision. So all macular degeneration is dry, okay? All macular degeneration is dry. The dry form of the macular degeneration really can't be treated, but the good news is it's usually slow and usually associated with good vision for a long period of time. The only macular degeneration we can treat is the wet form. So let me say that again. All macular degeneration is dry. So if the retina is dry, what it's trying to do is to bring blood vessels into those tissues to keep them alive. But it doesn't do it in a very good way. And so these new blood vessels grow in the wrong place, and particularly in the central part of your vision, which would then result in you seeing a black spot in the center of your vision. So that's what macular degeneration does. So with dry macular degeneration, it's a slow process. There's no treatment for it. With the pre-wet form of macular degeneration, so when we look in the back of your eye, the ophthalmologist will see these yellow spots. We call those drusins. And what that's telling us is that the retinal pigment epithelial cells aren't keeping up with supplying the photoreceptor cells with the nourishment they need, and they aren't converting the rod and cone pigments over fast enough, and so they collect. And when they collect, they create these yellow spots. We call those drusins. And so people with drusins, with macular degeneration, are more likely to go on and develop the wet form of macular degeneration. So for the drusins, so these yellow spots that you see up here, the treatment for that, as long as it's dry and it's not wet, is to use vitamins. Okay? So the eye-related eye disease study that was done at the National Eye Institute, when you use those vitamins, they prevent, when you have the drusins, the wet form of macular degeneration. So if you have dry macular degeneration, there's no evidence that taking these vitamins will help. But if you have the pre-wet form with the drusins, then the vitamins do help. It reduces the incidence of having the wet macular degeneration. If you go on and develop wet macular degeneration, okay, you'll have symptoms like a spot in your central part of your vision. You'll see a red spot you can't see through. And that's because a blood vessel from beneath the retina has broken through and it's now in the retina where your photoreceptor cells are. That hemorrhage and bleeding can cause permanent damage. So what your doctor can do for that, there's sometimes laser treatments that can be done. There are also injections using anti-VEGF growth factors, anti-vascular endothelial growth factors, using things like Lucentis, Avastin, okay? And the article in the Washington Post was talking how expensive Lucentis is, whereas Avastin is very inexpensive. Some people will respond to the Avastin. Some people don't. Some people only respond to Lucentis. So depending on how your macular degeneration, your wet form is going, your doctor may change the different therapies for that. So again, all macular degeneration is dry. If you have the pre-wet form, we treat that with vitamins. If you have the wet form, you actually have bleeding and hemorrhages and new vessels, then we treat that with anti-vascular endothelial growth factors, either with Lucentis or Avastin. Thank you for your attention.
David, thank you. Our third speaker today is Dr. Allison Ehrlich. I can't tell you how pleased we were with a little over a year ago, I think it was, when Allison agreed to take over as the chairman of our Department of Dermatology. She's also the director of the GW Psoriasis Clinic. She's listed among the Americans' top physicians by the Consumers Research Council of America. Is a graduate of the George Washington University School of Medicine, completed a residency at the University of Kansas Medical Center, and a master's in clinical research through an NIH Duke University program, also doing a clinical research fellowship at NIH. Dr. Ehrlich is an expert in the field of allergic contact dermatitis and specializes in skincare regimens for patients with sensitive skin. And today I think she's going to give us some more of an overview of skin problems with aging. Allison, nice to have you.
Thank you, Alan, and thank you for coming tonight on such a cold evening. I'm usually hibernating about now this time of the year. So I'm going to start talking a little bit about skin cancer, and then I'm going to kind of jump over to the cosmetic side. And we'll talk about how to slow the aging process, which I know a lot of you want to do. I certainly want to do it. So we'll talk, like I said, about skin cancer, some changes in our skin that occur over time, how we can prevent some of these changes, and some treatment options. So as far as skin cancer, before the precursor type of skin cancer is called an actinic keratoses. So for some people, it's a little confusing if you go to the dermatologist and they'll be like, oh yeah, that's a seborrheic keratoses. Oh yeah, that's an actinic keratoses. Well, there are different forms of keratoses, and it gets real confusing. The actinic ones are the precancers. The seborrheic keratoses are completely benign, and they look like all those stuck-on warts and growths all over your body. Some of my patients call them barnacles, and they actually are removable. The other types of skin cancer that we most frequently see are basal cell carcinoma, squamous cell carcinoma, and melanoma. So what about those actinic keratoses? So 10 to 15% over time will form into a skin cancer. This is why we like to treat them. They can be rough, scaly. They may be bleeding, and they may not be bleeding. They tend to be more apparent with sun exposure. So sometimes you'll see somebody in the spring and you're doing your skin exam, you don't really feel any spots on their face, and then they come back in the fall and they've got 5 new spots. And they just become more apparent with the sun. So this is an example of a patient with actinic keratoses. And let me see if I can get this little thing to work over here. So what you see are red, scaly lesions. And this is a patient with a lot of them. Sometimes you don't see the redness. Sometimes you just feel scaly spots. And I'll just run my fingers over somebody's face, and the spots that I feel that have that specific rough feeling, those are actinic keratoses, and I'll treat them. When somebody has this many, a lot of times we'll do cryotherapy, which is really cold liquid nitrogen, if there's just a few. But if you have this many, you need a whole field treatment. So we usually either would do something like a topical chemotherapy agent, or we would do a photosensitizer agent with exposure and then a light treatment. So we think of both basal cell carcinoma and squamous cell carcinoma as our non-melanoma skin cancers. These are the 2 most frequent kinds that we see. So the most important factor as far as causing these types of skin cancer is really sun exposure. And I know I have a lot of patients that come in and they say, I've been so good for the last 20 years, but the effect is actually cumulative. And it's not just what you did when you were 10 years old, actually. It's over your whole life. So if you have had skin cancers and you're like, oh, well, it doesn't matter anymore because I've already had some, it still does matter. So whenever you start, please try to be careful in the sun. Basal cell carcinoma is the most common type of skin cancer. It accounts for greater than 80% of the skin cancers diagnosed. If somebody has an easy risk of burning, if they're really fair and pasty like me, my brother calls me Casper because he's out there in the sun and I'm like under every umbrella possible. I'm at high risk, and anybody who's as fair as I am is also at high risk. So 80% are found on the head and neck. These are areas where you tend to get a lot of sun. And what does it look like? They can be non-healing sores. A lot of times we'll say a pearly papule. They have this like translucent pearliness to them. But one of the key things that we see if we're looking at with our magnified lens is you see little blood vessels kind of running through the lesion. Symptoms can be crusting, bleeding, or pain, or they can be completely asymptomatic. Squamous cell carcinoma is the 2nd most common skin cancer. There is an association with smoking and alcohol, however, also with prolonged sun exposure and a history of organ transplantation. I just saw a patient who had a renal transplant yesterday, actually, and did a few biopsies, and pretty sure they were all squamous cell carcinomas. They had that appearance. And what I mean by that appearance is a lot of times there'll be these exophytic papules, easy bleeding, you'll see, frequently crusting. However, sometimes, we talked about the actinic keratoses, 10 to 15% will go on to form skin cancer. It's usually squamous cell carcinoma. So if I have somebody that has actinic keratoses and they're like, This one right here kind of hurts. That's like a red flag to me, because if it's painful, I'm going to biopsy it, because it frequently can be one that's in that evolution phase, and you want to just biopsy the ones that are painful. What about melanoma? So melanoma we really worry about more because there's a higher risk of mortality with melanoma. The lifetime risk of melanoma for men in the US is about 1 in 58. The risk has doubled in the past 10 years. Hard to say whether it's the ozone issue or what, but it's going up. The median age of presentation is 45 to 55 years. In men, one of the most common areas is the back. So it's important to have somebody look at your back. In women, a lot of times it's the legs, because we like to wear skirts and dresses. And a lot of times we'll forget to put sunscreen on, or if we're wearing hose, it doesn't really protect us as much as we would like. So what are some of the things we think about looking for as far as pigmented lesions and melanoma? Asymmetry of the lesion, border irregularity, color being more than one color, and diameter. Now you can have what we call amelanotic melanomas that don't have any pigment, and those are really scary for dermatologists because it just doesn't look like the classic lesion. And I just had one a few weeks ago. So as far as what we see in this lesion, I want to point out some of those characteristics that we were just talking about. So you can see here there's two to three different colors. You can't really fold it in half evenly. It's regular, so asymmetric, and the borders are kind of scalloped over here. So this was actually a melanoma. How can we protect ourselves from skin cancer? Well, be really careful when you're outside. Try to avoid being out between 11 and 4 if possible. If you're out during those hours, try to wear as much sun protective clothing as you can, a wide brim hat. Baseball caps do not protect the sides of your face. So if you're out there playing golf, get a wide brim hat on, please. You want to apply sunscreen 30 minutes prior to going outdoors. And this is really, really important. Reapply every 2 hours, because if you think you're going to put on your sunscreen in the morning and go, play tennis, gardening, go do 18 holes of golf, and your sunscreen's going to last through all that, it's not. So you really need to reapply every 2 hours. If you're going swimming and you get out, reapply your sunscreen. Use an SPF 30 or above. Key areas would be ears, neck, face. Don't forget those lips. So one of the higher rates of metastasis as far as skin cancer is lips and hands. And one of the reasons for that is you have a higher blood supply to those areas. They're very vascular. So remember to get those lips in sunscreen or lip balm with sunscreen. And also the scalp. As we age, we tend to lose hair up here. And I've found not only in my male patients, but I've had several female patients over the years, and it's right where their part is. And that's where I found a skin cancer. So now the fun part. Okay. So we all want to look young like that, but I think the more important thing is really looking good for your age than younger than your age. You just want to look good at your age. What are some of the signs of aging skin? Increased pigmentation, irregular pigmentation occurs over time. Wrinkles, the other term for it we like is rhytides. So crow's feet, that would be the sides of your face. Glabella is this area kind of between your eyes. Forehead, nasolabial folds. These are all areas that we see wrinkling over time. The other thing that happens over time is the fat pads on your face kind of rotate with gravity and drift downward. So you kind of get this, you get a little sagginess up here where you didn't before. Broken blood vessels occur over time, both on the face and the legs, also even on the chest and neck. You get a change in the texture of the skin. So one of the differences that you see in people as they age is they don't have that light reflection. And when you lose that light reflection, the skin looks more sallow. How can we prevent photoprotection? Being really careful about sun exposure. topical retinoids over time. Antioxidants, maybe growth factors a little bit, but you have a harder time getting these things absorbed into the skin, so I don't think the science is as good behind some of these antioxidants and growth factors as it is behind topical retinoids. How do we treat some of these things? As far as the pigmentation, one type is called melasma, and this can be like that pregnancy mask, can be induced by hormones. It's recurrent and somewhat chronic, so we tend to do things that are easy to repeat over time, such as chemical peels, bleaching creams, and microdermabrasion. For sunspots, we sometimes use a little bleaching cream, but I tend to be a little more aggressive with these because if you can get rid of sunspots, they're not necessarily going to come back. So I tend to use more treatments such as intense pulse light or lasers. So what's the difference between intense pulse light and lasers? Well, with lasers, it's a coherent light source, so all of the light is traveling at the same wavelength. With something like IPL, it's filtered light, so it's not all at the same wavelength. Some of the lasers we use for treating brown spots are Q-switch 755, 1064, and I didn't put in here, but also a 532. So I'm going to show a few pictures as we go along here. So you can see here, this lady almost has a bronzing effect of her whole face. And there are some areas probably of her original skin type, which is almost looks hypopigmented here. And you can see quite a substantial improvement. This is with 3 treatments of an IPL, which is intense pulse light. So you can get really a nice improvement with that system. This is a condition called poikiloderma. You can get it on the chest. You also see it on the neck. It's a combination not only of the pigmentation, but also of broken blood vessels. And you can also get some nice improvement with an IPL. And you can see here the difference. Whoop, we're jumping. Sorry about that. Let me see if I can go. I'm not sure if I can go back. But you can see a nice difference on that one as far as the chest goes. Going on to treating the solar lentiginous, you can see kind of this really makes somebody's hands look quite a bit older when you see all those brown spots there. And if you can get rid of those brown spots, you really get a nicer looking appearance there. So the lasers we would use for this and the light systems we use for this, I'd either use a Q-switch laser. If I'm just seeing a few brown spots, I usually hit it with a 755. If it's really the whole hand, or if I'm doing like the full arm, which I'll frequently do, I probably do an IPL or intense pulse light first, and then I do a little later kind of clean touch-up with one of the Q-switch lasers to get whatever residual lesions are left. So treatment of broken blood vessels, there are a few different ways we can go about attacking these. On the face, I generally use a 595 long pulse laser. Sometimes I'll use an IPL or a 1064 if they're a little bit more purple of a lesion. What about the etiology of broken blood vessels? Some of it's genetic. So people who have that English, Irish, German background, really fair, flush, blush easily, those people are just prone. So the good thing is we can treat it. On the legs, there's sclerotherapy, venous closure, and laser that we can do. And the laser closure our vascular friends do, but we do the smaller vessels, little telangiectasias with laser or sclerotherapy. So as far as etiology on the legs, genetics, some people are just genetically prone to having a lot of broken blood vessels in their legs. Could be work-related if you're standing a lot at your job, and also pregnancy tends to cause new blood vessels forming on the legs. So this is just a nice example with several treatments with an IPL. You can really tone down that background redness. And one thing that patients like with this sort of treatment is that you don't get as strong of that flush reaction if you do have that blush. So it's hard to see with the light exactly here, but there's this whole patch or mat of little broken blood vessels arborizing like a tree almost here. And with 1 to 3 treatments, you can really get rid of a lot of these. And this is actually using a 595 long pulse vascular laser. So this kind of laser is also used for childhood hemangiomas. When we talk about wrinkles, we break it down into two groups, dynamic versus non-dynamic. Dynamic are ones that move with facial expressions. Non-dynamic are your more fixed. So early on, we use topical retinoids, light chemical peels, maybe some microdermabrasion to slow the process of those set wrinkles. As time goes on, we might move to neurotoxins such as Botox, some fillers, laser resurfacing. And then once you start moving beyond that, I send you to my plastic surgery friends for blepharoplasty and mini lifts. So I'm just going to show a few pictures as far as some products that we use. And you can see here this lady is frowning, and she's got some nice furrows or wrinkles here centrally. And some people say this is like the angry look, and they don't want to look angry anymore. And sometimes these lines get fixed over time. And you can see here, this patient had some Botox, which is a neurotoxin, and she's trying to frown, but she can't anymore. So it really softens those facial lines. If you don't want to look angry at work anymore, it's a great thing. So we also have a whole host of fillers we use to soften lines and change the face. And in this patient, she had fillers. These are the nasolabial folds here and here, and she had fillers in these areas. And you can see there's quite a nice softening of these lines here. So in this patient here, we actually were trying to improve her cheeks. So remember I was saying those fat pads kind of rotate and fall a bit with age. So we were trying to give her a more youthful appearance. And when you start adding a little volume in this area of the cheek, you can kind of give people a little bit more youthful of a look. So once we start moving beyond treating just the red and the brown with lasers, we can also do some resurfacing. There's two different variants, ablative and non-ablative. With ablative resurfacing, such as the CO2, there's more downtime. So a lot of my patients are working. They don't really want to take a week to 10 days off of work for a cosmetic procedure, but doing something they can do on a Friday and go back to work on Monday really fits in their schedules. So the 1550 Fraxel laser actually creates microthermal zones of destruction through the skin, and as it heals, it tightens the collagen, so you have some softening of fine lines. And what you can see here is these are her crow's, what we call the crow's feet area, and some nice softening of these lines. And this is after several treatments. So most of my patients, we do 5 treatments. The other thing that we use this laser for is for scar resurfacing. So post-surgical scars, we can get some nice improvement with this laser. And sometimes I also use it in combination with my 595 vascular laser. And every once in a while for keloidal lasers, I will go and use an ablative laser. This is another example of some softening of lines here. This was actually after 1 treatment. So if you do about another 4, you can get even more improvement. And you know, you really see that's nice reduction there. So in summary, skin exams are really important for early detection of skin cancer. It's good to have a baseline skin exam and then talk with your dermatologist about what the follow-up should be from there on. A lot of my patients come in once a year. If they've had several skin cancers, they might be seeing me every 3, or if they're high risk, they might be seeing me every 3 or 4 months. And there are some great treatment options for treating sunspots, wrinkles, broken blood vessels, and loss of volume for the face. And I just want to thank everybody for coming tonight in this cold weather. And thank you for having me, Alan. I'm taking stuff with me. It's okay. I didn't have a bell, you know.
The belt. I'm going to start by asking some questions that have appeared to me. And actually, one of the ththings I'm sure everybody wants to know is cochlear implants covered by Medicare?
The regular cochlear implants as of now are covered by Medicare. They only cover one side though. So for patients who have hearing loss in both ears, and there's data demonstrating that for most patients they do well with both ear being implanted. Unfortunately, Medicare only covers one.
Doesn't make a lot of sense, but, join the club.
Neither does the deficit. So.
Yeah, with everything else.
So.
David, what about the treatment for glaucoma? How is it treated? Is it a lifetime treatment?
If you have angle closure, many times that can be treated once with placing a hole in the iris with a laser, and usually that is curative if it's caught early. And so that can be a one-time episode of having angle closure glaucoma. Open angle glaucoma usually is a lifetime treatment. Can be treated with topical medications, laser, or actually cutting surgery.
Let me ask you one other question before I move on, and that's about cataracts. Can cataracts recur? I mean, in other words, you get them done in each eye once, are you then home free?
Yeah, as I had mentioned, you can get that after cataract. So you remove the central part of your lens, you leave the capsule in place, and in babies, 100% that will cloud up within a couple of days, so we'll actually make a hole in the front of your lens, in the back of the lens of a baby or a child, and then put the lens implant inside. But for the adults, you can clean it, it'll be clear, and most people have cataract surgery are 65 and older. And in that age group, about 10% the capsule will cloud up. And it's like the cataract coming back, but it's different. It's just the capsule clouding up. It's not interfering with the implant, and it can be lasered away in the clinic with a 5-minute procedure.
Okay. Is there any evidence that wearing contacts enhances cataract formation?
We're not aware of that, no.
Okay, that's good. Ashkan, is it better to get a hearing aid while your hearing is starting to go? Does it matter, or should you really wait till you're gone? What?
It's best to get them early on. Besides all the sort of emotional, social, and marital issues that hearing loss can cause, it's stimulating the neurons that go from the cochlea to the brain. So the more you stimulate them, at least theoretically, the longer they stay around.
Okay.
And this is a myth that hearing aids, because they amplify sound, they actually damage your native hearing. That has not been proven. So.
Okay. Allison, do basal cell skin cancers metastasize? And if so, or if not, is an emergence procedure, they have to be removed?
They have a very low rate of metastasis. So most of my patients, I say, you know what, if we're getting it off within 2 months, we're fine. But they should be removed. And one of the reasons why they should be removed is they can be locally aggressive. So I have seen somebody lose their eye to a basal cell. So you don't want to just leave them.
Is there any way to prevent liver spots rather than just remove them?
I'm sorry.
Prevent liver spots or prevent aging spots?
Yes, if you start sunscreen at a very early age, and wear gloves when you're driving.
That's for the pediatric talk. So we're going to forget about that today. That's not going to help us at all in this group. Ashkan, one of the things somebody asked about was acute hearing loss. You wake up and all of a sudden one ear you don't hear very well. What's going on, and what should you do about it?
So a great majority of the time that's a conductive issue, which is either there is wax or fluid in the middle ear. The dangerous type is when there's a nerve issue, and that is a true emergency. We have to see you within a few days. So a lot of times the hearing will never come back again. The way you can tell if it's a conductive or if it's a nerve is if you make a humming sound in your head, you'll hear it louder if it's a conductive sound. In the ear, you can't hear well. But if that nerve is gone, when you make the humming sound, you hear it better in the ear that is still working. So by just doing this little test at home, unless you have a tuning fork at home, you can always tell if the sound, if it's a nerve issue or not.
I always carry one with me. David, are cataracts inevitable if you have a family history? Is there any way you can avoid cataracts?
Stop having birthdays, but I don't recommend it. So.
I take that's a no. Are there different vitamins for macular degeneration, or is it just one vitamin that's out there these days?
Well, the age-related eye disease study, the one that was done at National Eye Institute, has a formula, and that formula is Bausch & Lomb is one of the makers. I have no conflict of interest. I have no interest in Bausch & Lomb, but that was the pharmaceutical that did participated in that age-related eye disease study. The vitamins are really, vitamin A is beta-carotene. Vitamins we think are harmless, but vitamin A in smokers increases the risk of lung cancer. Even above the risk of smoking, it increases it even higher. So you can change the vitamin A with lutein. The other things are zinc, selenium, and vitamin E are the other components, and they're high doses, but with that combination of medication, it has shown to slow the pre-wet form of macular degeneration and preventing it from going to the wet form. So usually you can look up AREDS, age-related eye disease study. If you see that on the vitamin and you have the pre-wet form, that's the vitamin you want to take.
Okay. Allison, what's Mohs surgery?
So Mohs surgery is micrographic surgery. So what happens is a Mohs surgeon is a dermatologist who's done a year fellowship after they complete their residency in Mohs surgery. When you're doing Mohs surgery, you take a small layer and then you actually process the tissue, look at it under the microscope while the patient is waiting. If the margins are clear on that first take, then you'll close up the patient. If the margins aren't clear, then you go back and take another layer of skin, process it, look at it in the microscope. So it can take several hours to actually complete the procedure, but it's one of the best ways to take care of skin cancer on the face because it's very tissue sparing in that you're not just taking a 5 mm margin to clear the lesion, you're just taking as much as you need to potentially clear the lesion and no more.
So we know melanoma can be fatal, but how do you tell in any one lesion if you're dealing with something dangerous or not?
Well, we would do a biopsy.
And
then we send it to the lab and see what the pathology report is. So if something looks suspicious, then we biopsy it.
And on the path report, what are the important aspects of it? Is it size, depth, or?
As far as a melanoma, it's usually not the size, it's the depth, but you're also looking at the mitosis rate and if there's infiltrating inflammatory cells. Those are things that they report on.
Okay. David, if you have high blood pressure, does that mean you're going to get glaucoma or get high pressures in your eye also?
No, get that question fairly frequently. There's a big resistor between your eye and your heart, so your heart is pumping blood to the eye. But what hypertension does affect is the small arterioles, the retinal arterial blood vessels in your eye. And so those blood vessels can also lead to hypertensive retinopathy, which can cause vision problems, hemorrhages, bleeding, microaneurysms. So your blood pressure doesn't cause glaucoma or pressure in the eye, which affects the optic nerve, but it does affect the blood vessels in your eye, which can also lead to blindness if it's not treated. And those changes in the blood vessels from your heart are separate from the pressure that's developed for glaucoma. So two different pressure systems. One is a vascular, which hypertension affects, causes hypertensive retinopathy. The other one is a pressure in the eye, which actually damages the optic nerve.
And if you're diabetic, are you more prone to any of these eye problems?
We used to think that diabetes was a high risk for glaucoma. It's probably a low risk. But diabetes causes other problems. It causes blood vessels to grow in the wrong places. It can grow in the drainage of the eye. It can cause bleeding in the eye, which can plug up the drainage of the eye. So it's not uncommon that with advanced diabetic changes that you may develop a neovascular type of glaucoma. Not the common open angle, but a neovascular glaucoma. It's just mostly particular for diabetics.
Okay. Monfort, is the use of cochlear implants becoming more frequent nowadays? And what happens after you get one? Do you have to reoperate at any point to replace batteries like you talked about?
So they're becoming much more common than they used to be. There's much more acceptance for them, particularly in the adult population compared to the childhood population. The internal device does not have a battery in it. The external device holds the battery, and the two communicate via magnet. So when you take the external device off, you actually don't see anything in the patient. So there's no issue with battery changes. Like every device, they do fail, unfortunately. The rate of failure of cochlear implants is about 1% a year. So they're fairly low, cumulative about 4% in 10 years. So it is very rare that we actually have to swap the device.
Do anything more, right. David, what's a freckle in the eye? Maybe that was for, not
Yes,
for you.
right. We see melanomas in the eye also, and so sometimes they're not things you want to biopsy, but they're characteristic signs or symptoms that we can see in the lesion inside the eye, and those melanomas can also metastasize and be lethal as well. But a freckle in the eye usually on the iris is truly a freckle. So something on the front part of your eye is like a freckle that you would see on your skin. When we think about a freckle in the back of the eye, it's in the choroid, and it's more of a nevus. It's a more organized clump of pigment cells. Now, nevuses also can turn into melanomas, which are cancerous pigmented cells.
Are these frequent or infrequent? Or?
They're fairly infrequent, yeah.
Okay. Allison, after treatment of the face with an IPL, do the blood vessels reoccur?
So I would say sometimes they can, particularly if people are going to be doing a lot of things that would put you at risk, such as if you're going to the beach a lot, if you're somebody who goes skiing a lot with those drastic temperature changes, it can cause them to recur. If you are getting pregnant again, a lot of times we see a lot more blood vessels that form during a pregnancy that can cause them to pop back.
What about medication?
Not generally.
Not so much?
No.
Okay. There was one other one that, what did I do with it? I'm sorry. Bear with me 1 second. Oh, I know what it was. The question was Botox versus Restylane. Is there a difference, and when would you use one versus the other?
Yes, actually there's a pretty large difference. So Botox is a neurotoxin. Restylane is a hyaluronic acid filler. So Botox you tend to use in dynamic lines such as forehead, glabellar, crow's feet, also in the lower chin a little bit to prevent that turn down of the mouth. Restylane you tend to use more in non-dynamic lines such as nasolabial folds. I also use Restylane for some of the lines around the lips, and also in the chin area you get some loss of volume on the lateral aspects of the chin over time, and so that to some degree causes your lips to droop on the sides. So we kind of use Restylane and other hyaluronic acid fillers to bolster up the lateral aspects of the chin so you don't get as much droop of the lips on the...
Do they give as much paralysis as the Botox, the Restylane?
It doesn't give any paralysis.
Doesn't give any paralysis. Okay.
As long as it's done right.
So you can still frown. You can still frown.
Well, you don't generally use Restylane. I'm saying generally because
Right.
you know everything's not 100%, but you generally don't use Restylane in the forehead area.
Okay. Dr. Monfort, I'm going to save the last question for you, and that is the frustration over hearing aids. They need to be adjusted, and is there a point in time where they just don't help anymore?
I mean, that's usually the threshold we use when we start thinking about cochlear implantation, is when the hearing aids are no longer helpful. Now, being frustrated with them just because they need battery change or other things, that's different. We talk about frustration when you really can't detect what sounds are, or the sound clarity is gone. The more powerful the hearing aid has to be, the more chances of occlusion, feedback, and all the sort of stigma that comes with a hearing aid there are. So when there comes a time that hearing aids are barely helpful or no longer helpful, we start thinking about implantation.
And do they wear out over time? The hearing aids themselves, not just the batteries, but the hearing aids themselves. I mean, do they
Well,
need
not
to be
only
replaced?
they need to be replaced like every digital device, is that the technology does change over time, and better softwares come along. When hearing aids went from an analog to a digital, there was a dramatic improvement in hearing aids. Now they do a lot more modulations with the softwares that they have inside them, and they allow things like, getting rid of background noise, shifting the frequencies to a lower frequency so people can use the natural hearing to hear them better. They also come with a lot of different bells and whistles of, connecting to your iPod and, all other things. There's a new technology that, it's actually not new by any means. It's new to Washington, D.C., and it's called looping system. And these are wire systems that could be installed in an office or in a building, and they directly communicate with hearing aids. The first and only place that I know in Washington, D.C. that have one is the Kennedy Center. So if you go to Kennedy Center now, the looping systems in the building will communicate with the hearing aid directly, so you won't miss any of the parts of the orchestra anymore. In New York, they have them in a lot more places, and in Europe, they're all over the place. So you can actually purchase them yourself and install them at home for your TV or for your conference room. So they will communicate directly with a hearing aid. They're very interesting.
It could be dangerous for your spouse, though.
Yes. So
They're
when
like-
eavesdrop on you, yes.
Is it like Google Glass for the ear, sort of?
Yeah, I mean, it's just a telecoil.
Yeah.
All telephones have them, but now instead of just having for a telephone, you can have it for a whole building. So.
Okay, well now it's time for the test. So I hope everybody learned something tonight. I tried to get to most of the questions. If I haven't, we got the panel here. Please come up and ask questions. Thank you so much for being with us tonight, and look forward to Healthy Aging Part 2. Okay, thank you.